We are all aware that with CAR T, we have entered a completely new therapeutic area with lots of opportunities, but also with several challenges. And it's beyond doubt that the currently presented results with CAR T in myeloma, they're really astonishing in terms of response and depth of response. But on the other hand, it's a very complex procedure. And so the CAR T cell infusion itself is only one step in a whole chain of events. And it all starts with selecting the right patient. And of course, currently, CAR T cells have been explored in patients who are already extensively pretreated. And we do know that, of course, the window of opportunity in those patients can be small because sometimes disease can relapse rapidly. Patients can have already some comorbidities related to previous treatment regimens, related to age. So we need to select our patients carefully. And CAR Ts are more applicable for patients with a disease that is only slowly progressing. And of course, there should not be significant organ damage, like damage to heart, kidneys, lungs, or liver. After careful selection of the patient, it's important that that patient has already been seen by the physician who will be responsible for the CAR T treatment so that it can be also discussed within the CAR T team. Once a patient has been approved to be a good candidate, then the next step is to collect the CAR T cells by apheresis. In that regard, it's important to discontinue all anti-myeloma drugs for 2 to 3 weeks, depending on the half-life of the drug. And then during the CAR T cell processing, which can take 4 to 6 weeks, so time between the apheresis and the infusion of the CAR T cells. So during that interval, of course, the myeloma itself can progress. So it's important then to give bridging therapy. And in patients with end-stage myeloma, it's sometimes very difficult to find a type of a new bridging therapy. So sometimes you have to rely on drugs or combinations that the patient has already been exposed to. It's also important to avoid that you would give a toxic regimen so that unforeseen complications like severe infections would occur, and therefore the CAR T infusion would be postponed or even worse, cannot be given. And then, of course, the important moment, the infusion. So just to remind you that CAR T cell infusion is preceded by a conditioning regimen, which is usually a combination of fludarabine and cyclophosphamide for 3 days. That's given from day -5 to day -3. And then on day 0, the CAR T cells are infused. That's really teamwork because CAR T cell infusion can come with some adverse events, and there's still a lot to learn. There's also a lot of discussion about that. Importantly, the adverse events are what one could call on-target adverse events, because CAR T cells is a type of precision medicine, and this is different from, for instance, off-target toxicities that can occur with conventional chemotherapy or with other compounds. So what are the most important adverse events that can occur? Well, there can be cytopenia. Cytopenia related to the conditioning treatment, but also to the CAR Ts themselves. And so this can be severe neutropenia, thrombocytopenia. Sometimes it can remain present for several weeks. And then, of course, there is a typical cytokine release syndrome. So cytokine release syndrome, or CRS, is a systemic inflammatory disorder. And it's related to the activation of the CAR T cells and also to stimulation of other compounds of the immune system. So typical symptom is fever, more than 38 degrees Celsius, but that's of course very atypical. And the organs most commonly involved with the CRS are cardiovascular system, so associated with hypotension and tachycardia as most common clinical presenting features. And then also hypoxia, which is primarily related to some form of capillary leak. But then, as indicated, it's a systemic disorder, so basically all other organs can become involved. What is important to know is that CRS will occur in the majority of patients. But when we look at CRS with anti-BCMA CAR T cells and multiple myeloma, fortunately, severe CRS is very rare. And death related to CRS is fortunately very exceptional. But still, one needs to be very aware that it can occur very early, even the same day of the CAR T infusion, or it can only start after 5 to 7 days. So it's important that the first 10 to 14 days, the patients are hospitalized whenever possible. And physicians need to be very aware of the signs and symptoms that can come with CRS, because as indicated, some are very atypical. And since the majority of patients are neutropenic, symptoms like fever, tachycardia, hypotension, or shortness of breath can also relate to other causes like infection. Another adverse event that can occur and that's feared is the so-called neurotoxicity. Now, to start with neurotoxicity with anti-BCMA CAR Ts, well, to reassure you, it is very rare. And if it occurs, it's again also mostly moderate or mild. Now, what are symptoms that can come with this neurotoxicity, so-called also ICANS, so symptoms related to the infusion of immune effector cells? Well, these can be very subtle or very overt. This can be related to dampening of the neurological system like somnolence or loss of attention, or on the other hand, it can give activating symptoms like even seizures. There are classical standard scoring systems to evaluate this, and these include, for instance, the assessment of the awareness, of the orientation, having people write a similar or an identical sentence every day, counting backwards. So very objective scales to score this eventual neurotoxicity. When it comes to treatment of CRS and neurotoxicity, so just to remind and to repeat, it's important to be aware, to know the symptoms, to score them objectively. And then the grading is according to CTCAE, so grade 1 to grade 4, mild, moderate, severe, and life-threatening. So normally with grade 1, CRS, nothing needs to be done except for supportive measures. With grade 2, then it is recommended in most protocols to give an anti-IL-6 tocilizumab. This can be given for 1 to 3 infusions at 8 milligrams per kg. And if that's not sufficient or a patient evolves to grade 3, then patients also need to receive steroids. But it is teamwork as indicated. So then, of course, the patient needs to be referred to an intensive care unit whenever possible. For the neurotoxicity, steroids can be given earlier, and also patients might need to be transferred to an intensive care unit for monitoring more early. And of course, this all in close collaboration with a neurologist who is well trained for detection of the side effects. But in conclusion, one can say that the adverse events of CAR Ts, they are very specific, but on the other hand, with a good knowledge, with good awareness and appropriate intervention, these adverse events, they are manageable. And one could say that severe or life-threatening toxicities with the anti-BCMA CAR T cells are very rare to exceptional.